All right, good afternoon, everyone. Thank you so much for joining. Hello and welcome to the 2021 SCID Compass Summit. My name is Emma Mertens and I am the Community Relations Manager for SCID Compass of the Immunodeficiency Foundation. Here today with us is Dr. May Baker, co-director of the Newborn Screening Laboratory in Wisconsin, Dr. Mary Beth Fasano, an allergist/immunologist at the University of Iowa, and Ruthanne Scheller, Senior Specialist for the Newborn Screening Technical Assistance and Evaluation Program at the Associate of Public Health Laboratories. They will be presenting a joint session discussing the unique newborn screening needs of premature infants. If interested, a PDF of the slides can be found and downloaded on this session's main page on the virtual platform agenda. A recording of this session will be uploaded to the virtual platform shortly after the session ends. Thank you so much and welcome, Dr. Baker, Dr. Fasano, and Ruthanne.
Thank you, everybody, and for attending. And also, I want to start with my presentation. Thank you, SCID Compass, give me the opportunity to present our work. So here is the disclaimer, and myself also do not have a conflict of interest to disclose. So again, before I started the presentation, I wanted to also adding on my thank you to Anne Atkins. And the data I presented here largely was collected and by her. So when we started this, actually it's back to 2008. Wisconsin started to newborn screening for SCID. And believe it or not, the first get our attention is the NICU babies, premature babies, because I think in the first week we have a screening, quote unquote, positive come from their population. So we quickly learned something have to be addressed because the neonatologist said, wait a minute, it's so hard for us to get the blood to do the flow cytometry, and we don't think they needed to. And they're right. So we quickly started to say, let's systematically address this issue. So our hypothesis and also think about the implication is such. And the T-cell receptor excision circle copy numbers and might different between pre and full-term newborns. Second is come to the practice point of view, the mature infant may require special consideration and in this newborn screen SCID. So first we want to really collect the data. So that's how we put a thing together for the study design. So we utilize first 6 months screening data. So we're screening about 35,000 individual newborns. And from that, we put two groups. One is we call the premature infant, which is anywhere below 37 just in age. So you can tell we decide for this study how we defined premature infants. And I hope it has some rationale because we do some research. We really think from the development point of view for T-cell maturation, the time may be more important than the birth rate, quote unquote, if you will. So also, of course, after the 37 and beyond, we define as a full term. So also we want to address, really is a biological question. So because of that, we purposely only including the screening, actually, quote unquote, negative cases. At the time, our cutoff, the threshold for track is equal or greater 25 per microliter. We also want to define the sample collection time. And if I do this again, I may do like 24, 48 hours because back in 2008, the timeless was not very emphasized. So we want more inclusion. So our majority samples were collected between 24 and 72 hours. So that's the kind of rationale. From that point of view, the criteria, we will identify 2,510 premature infant meeting our criteria. So we also want to match the full-term infant. So we chose 1 to 2 the ratio. Also, here we indicate, we say matched by plate. What that means is any premature infant selected, including for this study, will have exactly the same assay plate, because the purpose is we want to minimize the other facts. So normalize the value. That's what do. So together we have 7,530 samples for this study. So we collect the data, and the data analysis method is we really trying to establish the relationship between tracks and the gestation age in weeks. And to do this relationship, we utilize a linear regression model. And also the data was transformed to log scale before do the analysis to satisfy the modeling assumptions. So here's data. So I think the overall, you can tell study to, maybe I'm involved, I feel like straightforward. And so this is the data here. All the dots indicate each, the data point. I talk about the 7,530. So, and the X, on the X is the gestation age by weeks, and the Y is the track copy numbers, as I described earlier. And the plot showing all the data point, and the red line is really indicate the best fit, and indicate it's the have a linearity for the data points. So also we use the sum data and use the gestation age to present them. And you can tell, indeed, the track copy numbers is also statistically associated with the birth weight. So I want to make sure in general, I mean, to mention that is in general, gestation age and the birth weight largely going together, except you have an inter-euro growth retardation situation. So I'm not surprised to see that. And the reason we also want to present that is in the States, if they do not collect gestation age, they have another avenue to address the premature infant situation. So what the data tell us is actually track increase 10% every additional gestation week. So I think the data is very clean, pretty strong in my opinion. And also we learned low birth weight newborns are more likely to have a lower track numbers. And so based on that, we do conclude the premature infant requires special consideration during the newborn screening for SCID. So I think theoretically we was informed the hypothesis it's correct, but if you just stop here and do no good, right? So we take another step. So before I get in, oh, okay. So interesting, I thought I adding another slide, maybe I didn't get to the correct one, is this the scheme for our newborn screening in NICU is not unique to SCID. It's why it's important. So when you do anything in the newborn screening system, you're trying to be consistent, incorporated, integrate, and the fewer the exception you make, the better for the whole system works. So what I'm showing there, indeed, is for SCID, but also I can tell you on the top at the gestation age, 2 babies, the picture, actually our general NICU process is use a birth weight, like 2,000 200 grams. And the only thing we change is because as I stated earlier, and gestation age seems to make sense for this specific screening. So we just really is for SCID, instead of use birth weight, we utilize for congenital adrenal hyperplasia, we change it to gestation age. The rest is the same. So we already have established the NICU screening process, which is compared with the first term, most time we do one time, but for the NICU baby, no birth weight and premature babies, we call the targeted series screening. Majority of the reason really indeed is benefit is for the congenital hyperthyroid screening, because there have the premature babies have a delayed elevated TSH. So we utilize a model to fit in SCID without changing too much, because we talk about at birth and 2 weeks and 1 month, then until they're 3 months. So I think NICU doesn't really change much, and so help us. And also we do in our report, every single time we remind them, if this is a birth weight, if it's a gestation age below this, please follow your NICU procedure. So I think actually the practice point of view, we haven't encountered any problem. So from the data, you can tell, I'm just summarize again, is that we utilize the same track cutoff value to apply full term and preterm. The idea is make the process as straightforward, as simple as we can. But when we do the follow-up, indeed it's different. As I earlier said, is when in full term, we do screening, and if you don't cross the threshold, and the recommendation is the flow cytometry, confirmatory testing. If it's a preterm, and we ask a repeat newborn screening, when the gestation age and the real age adding together reach the 37 weeks, we would use our full term criteria applied. And I think one thing I need to mention that this is a general principle. It's a really help workflow, but situation can be exceptional, and you need to have this flexible. And in Wisconsin, the party is all the screening potentially false positive. I said it wrong. All the screening potentially screening positive. Actually, I personally review every single case. And if you have a gestation age at 34, 35, you have a track 0, and I likely, overturn the rules to get a flow. So I think you have to take this in your mind too. So now I just want to give you a little bit of snapshot and to say, with this kind of algorithm procedure, what are your screening outcomes? So I just simply use a 1 year, because our interesting thing is, since we screening SCID from, began in 2008. And over the time, we go through a different version. We use the internal standard. Now we use a multiple medium. And before we have the just a head track. Then now we have multiplexing with reference gene, and started October 2019, we adding on the SMA screening. Over the time, SS seems very stable, because every time we do some modification, you also need to do the fully validation, and we set the standard, because our team, when I say team, not just the newborn screening, also the follow-up, also our physicians, they really like where we are in terms of the positive predictive value, and how many teenopenias we identify, how many like a more classical CF. So we try to keep the consistency. So come back to the 2020, you can tell actually we totally screening the babies is a little bit shy from 60,000. So in that, the population in the whole 60,000 screening the babies, so we reported 16 full-term babies ask for repeat newborn screening, and I should specify, and the track assay is DNA based. So when you have a low track, also you have a low the Ruthanne gene, so that may indicate is really the sample quality. And this situation, we issue an inconclusive report. We ask repeat newborn screening. So that's why for term you have this category. So we have that, and we recommend the flow 19 cases. In these 19 cases, we have 11 indeed have somewhat degree lymphopenias. And actually, yeah. And so we totally have a 35 in terms of need somewhat follow-up actions. For the preterm, the ratios are very different, you can tell. So in our populations, about the 10% premature infant, you can tell. And in that inconclusive category, we have 56. And it's like 4 times more than the preterm. Even you have a 10%, the whole population, and some infant expired. And we do have one family, sick kids, they just don't want to do repeat newborn screening. So overall, there's a kind of general picture. And I think the confirmed cases actually, we have one is CHH, one is AT, and other ones is lymphopenias. And the one kiddo actually, it's, we have also have one 22q11 deletion syndrome. So that's all I have. I thank you for your attention. And I think I'm perhaps waiting for the end to answer questions that you may have.
Hello, everyone. Can you hear me okay and see my slides? Excellent, excellent. Oops, let's see. I have to make sure I can. There we go. I have no other conflicts or disclaimers. And everyone, hi, this is Mary Beth Fasano, and it really is a pleasure to join all of you at the SCID Compass 2021 Virtual Summit and to have the opportunity to share some clinical perspectives on SCID newborn screening in premature infants. Now, I am joining you from the University of Iowa here in Iowa City, which is in the eastern part of the state. Our state hygienic lab, actually, which performs all of the newborn screens, is actually located here in Ankeny, Iowa. Now, you might be interested in knowing that Iowa does the newborn screening for our neighbors, South Dakota and North Dakota, and our neighbor to the very far northwest, the great state of Alaska. Now, Iowa began its pilot back in June of 2013, and then we went live with our SCID newborn screen on July 1st of 2014. Now, like other states, we quickly confirmed the very high frequency of abnormal TREC levels in premature infants. And so we made our, whoops, I'm sorry, folks. We made our first change to our Premie Protocol in October of 2014, which was really just 3 months into going live. So at this time, in lieu of repeating a screen every 2 weeks until normal or 37 weeks, we made the decision to go straight to confirmatory testing with 3 indeterminates due to prematurity. And our confirmatory testing is obviously flow cytometry. Now, we are fortunate that our immunopathology lab here at the University of Iowa helped us to develop a special flow cytometry panel just for our SCID newborn screening protocol. And in addition to the standard absolute lymphocyte count, CD3, CD4, CD8, CD1656, and CD19, we also assess naive and memory T cells with CD45RA-RO. Now, in just a second, I'll share with you our review of data linked to this October 2014 change, along with some stakeholder feedback that we received. And it was really that interim assessment that led us to make the most recent change in our Premie Protocol, which occurred in December of 2019. Now, although we were initially pleased with the 2014 revised Premie Protocol, we began to receive concerning feedback from our neonatology team. Now, some of this may have been related to really the relatively high number of extremely premature infants admitted to our NICU. And in fact, with recent data here in Iowa, we have over approximately 900 NICU admissions per year, of which 25% were less than 31 weeks gestation. And although our team has fantastic success with an overall survival of 78% in the 22 to 23 week preemie and 89% in the 24 to 25 week preemies, the high frequency of abnormal SCID newborn screens in this population raised concerns and questions within our entire NICU team. So let me share some NICU stakeholder feedback that we received, which included increasing concerns over the need for repeated screens in these very premature infants. Parental and other caregiver anxiety over the labeling of a presumptive positive SCID in a baby already very fragile, often critically ill. And then the repeated concerns over the need for additional blood draws of almost any volume to further evaluate the clinically significant T-cell lymphopenia seen on flow cytometry in these very premature, very low birth weight infants. The ultimate result, truly in the large majority of these preemies, was a false positive SCID newborn screen or a transient T-cell lymphopenia. But anyway, this then led to perhaps one of the most concerning comments that we were receiving from our NICU team, that being distrust of the screening results, which extended beyond SCID newborn screen and into really any of the disorders Iowa screens for as part of our newborn screening program. So to address these concerns, we pulled our data from 2015 to 2019 and looked at the number of abnormal screens and final outcomes for the different preemie gestational ages that you see on this table. So let me walk you through this. Of the 105 22 to 26 week preemies, the vast majority had normal screens on the second or third repeat. And of those that went on to confirmatory testing with flow cytometry, the results were not considered clinically significant or were ultimately found to be transient. of the 115 27 to 30 week preemies, we had 106 of these had normal repeat screens by either the second or third screen. And again, of those that went to flow cytometry, it was either deemed not clinically significant T-cell lymphopenia or ultimately to be transient. We did have one charge baby. And finally, in the 31 to 36 week group, we had 121 preemies with an initial indeterminate due to prematurity. And as you can see in this group, the bulk normalized with subsequent screens, and we did not miss the 35 weeker with cartilage hair hypoplasia or the 36 weeker with ADA SCID. So based on our initial review of this 2015 to 2019 data, as well as the input I just shared with you from our NICU stakeholders, we moved to our current Premie protocol in December of 2019. And let me walk through this with you with each individual slide. So in the first group, so these would be our very premature infants, our 22, 23, 24 weekers. So any preemie less than 34 weeks with an initial screen, which is indeterminate due to prematurity. So even if this is a 22 weeker, we do not request that repeat SCID newborn screen until 34 weeks. If again, that is indeterminate due to prematurity, we repeat at 36 weeks. And if again, indeterminate due to prematurity, we proceed then to our confirmatory testing of flow cytometry. Next, for the infants who are 34 to just shy of 36 weeks with an initial indeterminate due to prematurity, we repeat at 36 weeks. If indeterminate due to prematurity at that time, we move to confirmatory testing. And then finally, for the 36 to 30, just shy of 37 week preemie, if their initial screen again is indeterminate due to prematurity, we repeat that 7 days later. And if abnormal, that is reported as a presumptive positive. And of course, at that point, we move to our confirmatory testing. So what have we seen with this most recent change? So let me share with you our data review from December 18th, 2019 to March 18th of this year, during which time we screened 44,391 Iowa babies. During this time, we had 69 infants who had that initial SCID newborn screen indeterminate due to prematurity, and we broke them down into, this is our 22 to 33 week gestation. Of these, 49 of the 69, or 71%, had a normal second screen, which again, based on our Premie protocol, we would not request that second screen until 34 weeks. We had an additional 11 of those babies who had a normal screen. Again, per our current protocol, that would then be at the 36 week time point. And then we have 2 cases which remain open at this time. Now, though I cannot share with you specific information from the other states for which our lab performs the newborn screens, I can tell you that from looking at general data from South Dakota, North Dakota, and Alaska, 74% of these 22 to 33 weekers had normal repeat second screens. So across the board, our new protocol has resulted in a significant decrease in the number of repeat screens needed and the need to have blood drawn for confirmatory testing and or additional workup moving forward. So the next group, again, this is the 34 to 36 weekers, data from December 2019 to March 2021, looking at the 44,391 Iowa babies. Of these 10, 80% had a normal second screen at what would have been requested at that 36-week time frame, and we had one who's a presumed cartilage hair hypoplasia. Again, summary data from North Dakota, South Dakota, and Alaska showed that of the infants in this Premie group, actually 100% had a normal screen at the 36-week time frame. Now, we continue to monitor our data with the new Premie Protocol, but we have been very pleased from the data standpoint thus far. But what about stakeholder feedback? Clearly a critical element, and I would like to now briefly review that with you. So over the past sort of 2 months, we've surveyed key stakeholders, including, those in our state hygienic lab, those involved with our short-term follow-up unit, and our neonatology team. From the lab, the change is a huge positive, with a significant decrease in false positives, and the number of preemies needing to have blood sent for flow has dramatically decreased. From our short-term follow-up team, the impact has been incredible. Vast difference in the follow-up burden and fewer follow-up calls. Don't have to chase down providers. And this saves families a great deal of stress. And then finally, from our NICU team, changes have been wonderful. And as an aside, this has significantly improved the working relationship between our entire newborn screening team and the neonatologists. So as the saying goes, if you've seen one state's newborn screening protocol, you've seen one state's newborn screening protocol. But with that said, thank you for letting us share our Iowa experiences with you. The changes to our Premie Protocol have been very positive, and we continue to track data to assure rigor and effectiveness of how we manage SCID newborn screening in our premature infants. And finally, a special shout out to the Iowa SCID newborn screening team, who enables us to optimize the care of our very precious newborns. So thank you very much, folks. And I am gonna stop share and turn it on over, I think, to Ruthanne, who's next.
Wonderful. Thank you, Dr. Fasano. Hi, everyone. This is Ruthanne Scheller. I am tuning in from Silver Spring, Maryland today. I have no other conflicts to report. And I wanted to thank you all so much for this opportunity today to share some information about our SCID screening for premature infants quality improvement project. It's really an honor to be able to present along Drs. Fasano and Baker this morning. Dr. Baker and her team were actually part of our quality improvement project, and they've played a really instrumental role in the design and implementation of this project. So many thanks to her and her team, and many thanks to both of my co-presenters for sharing your state's experiences and sharing some helpful background for my presentation today. My role through my role at the Association of Public Health Laboratories, I've had the privilege of working with the IDF and newborn screening programs for the past 6 years. And just to give you a little bit of background, our goal at APHL is to strengthen the role of public health laboratories in population newborn screening, as well as to design strategies to address the changes in the field of newborn screening. So before I kind of delve into my slides, I first wanted to thank our funders at the Health Resources and Services Administration, as well as the Immunodeficiency Foundation. They've been very supportive of this project, and we're very grateful for the opportunity to continue to work with them to support newborn screening programs and education programs through the SCID Compass program. All right, so some quick background. I quickly wanted to touch on the history of SCID newborn screening. So back in May of 2010, SCID was added to the recommended uniform screening panel. And it wasn't until December of 2008 that we celebrated all 53 newborn screening programs within the United States and associated territories offering SCID newborn screening. Dr. Kajana and Stevens with the New York Newborn Screening Program shared a really nice overview yesterday of some of the complexities involved with SCID screening. And as they mentioned, the addition of SCID to newborn screening programs panels pose challenges as well as opportunities. This addition required programs to integrate new screening technology within their laboratories, to train newborn screening personnel on this technology, as well as to establish clinical referral networks. So over the years, with ongoing experience with the screen, as well as advancements in neonatology, this has really led to the need to continuously evaluate SCID newborn screening algorithms. So in February of 2020, New Steps, which is a program of APHL, along with the SCID Compass program and our partners at the Newborn Screening Translational Research Network, MBS-TRN, we hosted a SCID national webinar for newborn screening staff. And this webinar focused on the challenges associated with screening preterm, low birth weight, and NICU babies. During this webinar, my co-presenter, Dr. Fasano, along with Carol Johnson with the Iowa Newborn Screening Program, they shared a very similar presentation to the one that we heard today, and they highlighted some of the challenges that have emerged regarding screening this population since they went live with SCID newborn screening in 2014. Following their presentation, we launched a live poll to all participants to see if other programs could in fact relate to some of the challenges that Iowa was experiencing, and if so, if they would be interested in participating in a multi-state project. This national project would allow us to get not only a better sense of what's working well, but we would also get a better understanding of what's not working so well. And it would also offer some guidance as to what might eventually be considered a best practice. The poll results were really interesting in terms of this being recognized as a widespread issue, and that many sites already appeared to collect a lot of data that would be needed for a multi-site analysis. So with the support from our funders, we're really grateful for the opportunity to be able to move forward with this national quality improvement project. That will take a closer look at some of these issues. And over the next few slides, I'll share some more information about the study design and our goals for this project. So what we know now, newborn screening for SCID by measurement of T cell receptor excision circles, also known as TREX, successfully identifies newborns with SCID and severe T cell lymphopenia as intended. At the same time, screening programs are facing challenges of high false positive results, especially a disproportionately high number in the premature infant population. Generally, these false positives are due to the relative immaturity of a premature infant's immune system and T cell development at the time of newborn screening. And as a result of the high number of screen positive results in this population, premature infants are often screened multiple times. And as Dr. Baker and Dr. Fasano mentioned, they may undergo unnecessary diagnostic testing in an effort to further delineate the screening results. So through this quality improvement project, we propose to evaluate characteristics and outcomes of SCID screening in premature infants among multiple state newborn screening programs and identify best practices in handling and providing recommendations for low-TREC newborn screening results in different gestational ages or birth weight groups. Successful completion of our project will result in strategies that could reduce the unnecessary follow-up activities associated with SCID screening false positive results in premature infants. So to get to this completion goal, we've identified 3 specific aims. For specific Aim 1, all newborn screening programs participating in this project will be asked to provide de-identified individual SCID screening related data for babies born between 2018 and 2020, as well as aggregate SCID screening related data for babies born between 2018 and 2020. We'll also be requesting that programs provide additional programmatic information such as the number of screens that were collected for each baby. And we'd also like to know whether they're already utilizing a serial screening protocol for their NICU patients. We then plan to take a close look at relevant statistics from all the states to quantify screening performance metrics and the clinical impact on various categories of newborns, categorized by their gestational and birth weight. For specific Aim 2, using the data that I just mentioned, we'll take a closer look at average and median TREC values along with their ranges in the hopes of getting a better understanding and graphically representing the trajectory of TREC values across both birth weight and gestational ages. And then for specific Aim 3, using the outcomes and information provided by our analyses, we'll develop a recommendation for potential best practices for both screening and follow-up algorithms. So on this slide, you'll see a visual of the 15 programs that have expressed interest in participating. These states account for 40.6% of all the births in the US. So it's really quite a nice representation. And as far as our current progress on this project and our intended timeline, this slide captures some highlights. So back in September, APHL invited all newborn screening programs to attend a webinar that provided an overview of the project. Following that webinar, we received interest from the 15 programs that were on the previous slide. Then in October, we submitted an application for full institutional review board exemption to the University of Wisconsin, and we were very pleased that this project was recognized as IRB exempt. Then in December, APHL invited programs to join us for part 1 of a data review call, where we discussed some of the case level data elements we were intending to collect. And during this call, we received really helpful feedback from states regarding the feasibility of providing these case data elements. We also received some concerns regarding the volume of data that we were initially hoping to collect. So in response to these concerns, we invited a biostatistician from the University of Wisconsin-Madison to join our project team. And he's been fabulous in really helping us think through how to make this data request as manageable as possible for programs. We then held part 2 of a data review call to discuss the aggregate level data elements we were intending to collect. And during that call, we shared some of the data considerations that were discussed during part 1 of the call. We are very excited to now be moving forward with our pilot stage. We're working with 3 states to test out our data collection and submission process through a very secure electronic portal. And we plan to share any lessons that we learn with these states during this pilot stage with the other states that will be participating in this process. We're also, throughout this data collection and submission process, our project team's available to help with technical assistance support or answer any data-related questions that states may have. And we're hoping that by the end of this summer, early fall, we'll be able to really take a close look at all the data that was provided, conduct a thorough analysis, and then draft an evidence-based recommendation that we'll share with IDF and other experts. And once that's approved, our goal is to disseminate this recommendation to all newborn screening programs. So with that, I'd really like to give a special thanks to all the folks on this slide, especially the SCID Quality Improvement Project team. They've been fabulous to work with. Our SCID partners and all of the newborn screening programs. You all are a constant inspiration, and it's been amazing to see, despite all of the extraordinary challenges that have emerged throughout this past year and with COVID, you've really worked around the clock to continue to look out for newborns and to volunteer for projects such as this. So we're so grateful. I did notice that there are several newborn screening program representatives tuning into the call today. So please feel free to reach out to me if you're interested in participating. We'd love to have you. Also, if you have any SCID related technical assistance needs, we're here for you. So my name or my email and number are listed on this slide. And many thanks to everyone on this call for tuning in today.
Thank you so much, Dr. Baker, Dr. Fasano, and Ruthanne. We do have some time, just about 12 minutes, for any questions or comments. The chat is open, so if you have something you'd like to share, please do so. And I can also open the opportunity for you to unmute yourselves if you have any questions that are maybe a little more complex and you'd rather say them aloud than type them out. So thank you again.
When people get ready to ask questions, I want to just have a clarification to make. I didn't think I said that. In terms of NICU procedure, is regardless of your screening for SCID result, they just happen. As I indicated, is for congenital hyperthyroidism, you need to do the multiple screening to be sure you don't have false negative. So for SCID literature, you don't ask an additional sample. They come in regardless. But internally, our software to match this. If you first screening didn't get cleared, is on that. We know there's premature babies, and software knows that they don't do anything until the second screening in, and they will match up. Then they will off the list. So that's all the automatic thing behind the thing. And we have the similar results as Iowa in terms of percentage, how many get cleared and at the second screening come in. Thank you. I just saw the chart. I don't know what I just specified the clarification and answer your question. It's a lot of things, even we describe in such a fashion, anything actually you don't do additional thing, it's just there.
I can see the little green rectangle, so you can probably hear me. So with May, so what was their final yield after you do the second screening test for the premature babies or babies in the NICU?
Okay, so I think I think I trying to say is with our data, again, I want to emphasize second screening usually happen 2 weeks. This regardless you have a screening positive for SCID or not, because this uniformity to do that. And the data, about 83, 85%, they just quote unquote cross the threshold. And this is my little bit suspicion here is because a lot of especially very low, premature babies there, the mother delivery have the sterile injection, whatever, seems like just temporarily, suppress the immune system. And so after 2 weeks, they're back up. And 85%, again, I want to emphasize, it's not, it's also automatically, if I may use a term, is in the data system because of the automatic matching system, they were just out of a list. So our attention really is emphasized on the ones I reported that is we eventually have to manually do some action. I hope I answered the question.
Yeah. And then Mary Beth, you showed us your yield where it really does help to do the subsequent tests.
Yeah, I want to emphasize because for the two screening stage, they can advantage, they have that. And I do believe it's a very common practice when states have a one screening, they do have this called a targeted second screening because congenital hyperthyroidism screening the needs. So we really adopt this, whatever already there, just adding on this. So you really don't ask a specific specimen to repeat. And another practice in newborn screening field is when you have a specimen come in, you usually don't try to sorting out what it is. You still go through the process, then the computer match up, see what you previously result and the current result, and together you can decide how you report out. So.
This is Mary Beth, and actually, I do see there is some questions in the chat box for me. The one is, and I guess similar to Wisconsin, we're a one-screen state, but also, you know, obviously our screen is for a variety of different disorders, and so anytime a repeat screen is needed or requested for another disorder, our state hygienic lab runs the entire panel, which then would, even if not specifically requested for SCID, that track still gets rerun if another dried blood spot card is requested for something else. I think that was one of the questions that came in, and May, that sounds like similar to what you folks are doing there in Wisconsin. And I was pleased to see also just sort of, I think, although we looked at data slightly differently, there are a lot of similar themes that Iowa and Wisconsin are seeing. I do see real quick in the chat box, there's another question. When do you go to genetic testing for plausible gene causes of SCID? Well, so obviously it depends on sometimes patient-specific scenarios, but I guess if just simply put, if this is helpful, certainly if we're at a point where we've moved to confirmatory testing with flow cytometry, if that is concerning for clinically significant T-cell lymphopenia, we do go ahead and our lab is fantastic with small volume of blood, request T-cell proliferation to PHA to assess T-cell function. But then again, based on the scenario, we are really pretty doggone quick to go straight to mutational testing. And that's true. I mean, but I'm speaking in general terms, not unique again to the Premie group, because in the Premie group, so many of them, as they get older, their thymuses grow. What was it, May? You said 10%. The TRK levels go up 10% a week in your group.
Yeah, the TRK numbers increase by 10% each week.
Yeah. We might go with mutational testing. I hope that sort of answered your question.
So Mary Beth, may I ask the follow-up question regarding this genetics? Because when we have early on started screening, and I think the practice at time is you want to find a molecular etiology before you decide to do bone marrow transplant. And my observation is over the time, because newborn screening really changed the whole, this dynamic. I think at least in Wisconsin, the molecular etiology is not a necessary must to have it before you go on the bone marrow transplant. Am I right?
Absolutely. And that's sort of the Iowa thought. I mean, with SCID newborn screening, we are learning that what we thought was a typical presentation or what the standard mutations were, we have now learned that there are so many novel or new mutations that are coming out. So that goes back to the piece of if we have a baby who has clinically significant T-cell lymphopenia and whose proliferative response to PHA is grossly abnormal. If we have, what do I want to say, the immunologic or the clinical phenotype that tells us this baby is a SCID. Even if we do not have a mutation, we will work with our transplant team to get that baby prepped and ready to go for transplant. Yeah.
I had another question from California. We started doing multiple punches years ago. You know, if it's positive, there'll be 4 punches, and finally we were picking one, you know, the meaner of those punches, and that reduced a lot of variability, especially among the premature babies, because it seems as if premature babies, they are producing TREX. We have a paper that shows that they're doing that, and also their immune system, CD3, CD4, CD8, go up over time as they get a little older. You know, it's very consistent. So they're producing their immune system rather quickly. But there's some variability in where you punch. So if you punch 4 times, there's enough variability that some of the punches end up in the negative range. And that actually saved us, you know, a significant percentage of false positives. That has helped. So I don't know if anybody else does that, but that's the peculiarity of California.
So, Beth, Mary Beth, I can take it on first because
Please,
the
yes.
laboratory practice and understand what you described. Actually, it's if I can even use the term, well, I can use a term like common practice, and also if I can go further, I will say standardized practice. And because you want to take the high throughput, you usually start with the 1 punch first, and not just for SCID, tandem aspect, any assay. When you have this 1 punch, you have a question, you immediately retest. In our laboratory, my knowledge is most laboratories do the duplicates. So you have 3 data points. So indeed, that will limit it certain, because our rule is 2 of 3. And also when we re-punch the samples, we intentionally punch a different circle because you have 5 circles. So you're really trying to have a more broad. And one thing I would mention that we don't average them. And we just based on the 3 and we make a decision. And and also again, we have a reference gene as a marker to say, hey, you really think how, you know, compare with the NSP, this kind of thing. So that is not, I wouldn't say this is unique to any program.
Thanks. Thanks. Yeah, we found averaging worked better for us. You know, it gets into the idea of moms and, you know, the variability of the premature babies. You know, they're a different, what would you say? They have a different profile, really. And you're catching the punches at the extreme end in that for those kids.
I think really you hit the key thing. This is a really special population.
Yeah.
And not only biology, but also, like I said, the premature baby potentially, I mean, like very likely the mother received the steroid therapy, whatever, like you mentioned very well, it's transient, right? And they're a little bit lower, but there's after all this environmental factor. And also, I want to mention that when we address premature infant situation, they compare with full term, they have a disproportional higher. And that means the premature baby does not produce a track. And the majority of them still screening negative correctly.
Thank you.
I just want to pop in and say thank you, everyone, for your wonderful questions and comments. Other sessions have started now, and this one will time out in just about 7 minutes at 1:10 p.m. Eastern. So if you have any more questions for the fantastic team of Dr. Baker, Dr. Fasano, and Ruthanne, please add them to the chat or ask them aloud quickly. There's just about less than 7 minutes left. Thanks, everyone.
Want to chime in a little bit as a skeptic, so to speak. From looking at our data, I mean, I think maybe perhaps different newborn screening programs minimize the burden on the NICU in different ways. And from our data, most of our preemies have very normal treks. And the specialists in Massachusetts have long felt that because most preemies in Massachusetts have very normal treks, that they want to act on the ones who don't. We do a repeat protocol and an undetectable protocol, but once a preemie, no matter the gestational age, has 2 out-of-range results, they go to flow cytometry pretty much without question. So just as a differing viewpoint.
Yeah, thank you for sharing with us. And again, you emphasize, which is we are talking about the majority premature infants and likely have screening negative. But interesting, you talk about your procedure, and you have to make some decision based on your data. And I think it makes perfect sense to me. My question for you is, for the premature babies, and you do the flow, what are the positive predicted value on that?
I'd have to go back and look at the data. I don't have it quite at my fingertips, but quite a few of them have had some significant lymphopenias that the NICU wanted to know about. So, I mean, we've had,
and I think,
had a couple of NICU kids with SCID, one of whom was quite ill, and everyone was focused on the child having cystic fibrosis, despite having normal CF newborn screening results, and it was SCID. So,
another thing, since we shared our thoughts, and I think in general, I have a little bit less concern about the NICU babies. So the reason is they are under care. Every NICU will have the basic, I would like to hear what Mary Beth said, because to my point is most of the kids, almost everybody, not almost, maybe everybody in a NICU admission, you have a general CBC differential. If very severe teenopenias, you don't need a track to pick it up. So because when I have this NICU situation, sometimes I just call. The reason is I want to learn in terms of different scenario. And also I want to try to match how the track performs compared with CBC. They're not on our cards. So I make a phone call, and to my pleasant surprise, how much they go together. So I think for that reason, I feel like unlikely we will miss severe teenopenias in the NICU population the way we are doing.
I just have maybe 2 quick comments and follow up to what Jamie brought to the table regarding her experience. First thing is absolutely, we have had preemies even in the 22, 23, 24 week gestation group who have had normal initial SCID newborn screens. We haven't gone back and actually looked at percentages and data and compared gestational age with birth weight in more detail. That might be helpful for us to do. The other piece, and I think many of you guys may be aware, I think it was in 2018 or 2019, Jennifer Puck and her group published in the Journal of Allergy and Clinical Immunology specific, I guess I'll call it normative ranges for lymphocyte subsets in premature infants of different effective gestational age, and also showed those ranges for different birth weights and babies' weights. We have now incorporated those reference ranges, if you will, into how we interpret our preemie flow cytometry. And that also has been helpful when we look at confirmatory testing and make the decision about whether we feel this is clinically significant T-cell lymphopenia or not.
Oh, thanks. That's really interesting. I will add, we actually, once we observe a normal TREC result in a NICU baby, if it's their first specimen and then one of their routine NICU specimens is subsequently shows low TRECs, we actually report out the value as out of range, but we don't require any further follow-up on those babies. So basically, once you have a normal TREC, it kind of buys you out a follow-up in Massachusetts. And that, I think that certainly helped the NICUs. I know when we were starting in 2009, it was the kids that were fluctuating up and down that seemed to be particularly challenging.
Yeah, Jamie, thank you for bringing this point too. It's we have the category we reported as previously SCID screening negative, because not only what you described NICU procedure, premature infant situation, also the surgical, because you have the cardiac surgery and you at birth, you have perfect numbers, and after cardiac surgery, and you have a partially thymus removed, and the track number is day and night. And again, we see that. So it's, I think the same philosophy our immunologist said, when you're at birth, this is perhaps the most reliable marker. Of course, I'm not talking about I think we learned in terms of maternal, the contamination is very, very low because adults have a very, very low. And also another situation in terms of blood transfusion in our program, blood transfusion, we really see is a dilute effect. So when you have blood transfusion, you have normal TRECs. Actually, we don't say this interfere, we let it go. So I think it's a lot of things into this. Thank you for bringing all this to this discussion.
And thank you, everyone. That is all the time we have for today. The chat feature is available on the Passable platform if you'd like to continue any discussion. Thank you again to Dr. Fasano, Dr. Baker, and Ruthanne for sharing all they have today about the importance of screening premature infants for SCID. Have a great rest of your day and a great weekend, and take care, everyone. Thank you.